Our last lecture is going to cover the high-risk newborn. So the first thing we're going to talk about is something called intrauterine growth restriction. It used to be called intrauterine growth retardation, but they're interchangeable words. This can be both symmetrical or asymmetrical, and where the fetus has not reached their potential growth due to either genetic factors or environmental factors. So this is an example of a baby with IUGR on the left compared to the average sized baby at the same gestational age, which is term. So notice this baby is much tinier than this baby, and it had some growth restriction due to sometimes, like I said, a genetic factor or an environmental factor, like the uterus was tiny or the placenta was smaller, so the baby received less food and nutrients. So there's a variety of factors that can contribute to IUGR. So the maternal causes that are associated with this can be chronic hypertension or hypertensive disorders of pregnancy. Both can cause the placenta to prematurely age, and scar tissue, which can cause less perfusion to get to the baby. Autoimmune disorders, smoking, which again can affect the placenta as well, substance abuse, or uterine malformations. If you have a uterus with a lot of fibroids or a malformation called a bicoordinate uterus, which is where there's a septum in the uterus that can cause the uterine area in which the baby lives in to be much smaller than the average uterus, and that can cause their growth to be restricted as well. Other placental or umbilical cord causes can be twin-to-twin transfusion, which we talked about before, about how one twin got more nutrients and blood flow and oxygen than the other. A chronic abruption, so remember we talked about if there's a small abruption, but it's over a long period of time, that baby is getting not 100% of what the placenta could give them in terms of blood flow and perfusion. A placenta previa can cause this, an abnormal cord insertion like a velamentous insertion, where the cord implants in the wrong side of the placenta, or multiple gestation, just for the sheer fact that multiple babies are sharing the same space that one baby would normally have the room to grow. And this is just an example of what we talk about when we refer to large, small, and appropriate for gestational age, which we reviewed a little bit in the normal newborn. But this is just I'll show you an example of what a chart would look like, how we graph the weight of the baby in grams versus the gestational age. And then we put that baby's weight on there, and it tells us where they fall in that weight category as far as, is it small for their gestational age, is it large, or is it average? So if a baby is small for gestational age, that means their growth is less than that 10 percentile on that chart from before, or has weight of less weight than all the fetuses of that gestational age. So risk factors that can cause a baby to be SGA can be maternal, fetal, or placental. Neonates are at higher risk for labor intolerance, hypoglycemia, or hypocalcemia if they are born SGA. And the assessment findings are often a large head and a large anterior fontanelle as compared to the body, thin extremities and trunk, a decreased amount of Wharton's jelly or that protective coating around the umbilical cord, and dry, flaky skin. The baby who is large for gestational age is where their weight, length, or head circumference measures above the 90th percent of gestational age. Those risk factors can include maternal diabetes, prolonged pregnancy, so past your term or your due date, a previous macrosomic baby. The neonates who are born at LGA are at risk for birth trauma. Remember, the bigger they are, the harder it is to get out of the birth canal. So you're thinking bruising, nerve damage, shoulder dystocias, possible C-section. They also are at risk once they're born to have hypoglycemia because they are used to getting an enormous amount of sugar in utero, which is causing them to get bigger and bigger, as well as they are now making more insulin because of that, because they were used to getting a good amount of sugar during the gestational period, that once, they have a stored insulin as well. So once they're born, they're not getting as much sugar as they were used to getting it in constant supply once they were in utero. And in addition to that, they're releasing the insulin that they have produced. So that, in combination of not getting a lot of the sugar, causes them to be hypoglycemic. They're also at risk for hyperbilirubemia because of the possibility of bruising and broken red blood cells. The assessment findings we would see is the hypoglycemia, the birth traumas, and the hyperbilirubemia, or jaundice. In the post-term neonate, those are born after 42 weeks. And remember, sometimes people use this interchangeably with post-dates, but technically they are not the same thing. Post-dates is after 40 weeks, but still term, and post-term is after 42 weeks. So the risk factors for this is to have, is the previous post-term pregnancy. So if you just happen to have pregnancies that tend to go post-term, maternal obesity can cause this. There is a sulfatase deficiency in the placenta when you get past your post-term dates. And in addition to the placenta aging, it also can have a deficiency in this key enzyme in estrogen for the placenta. And the lack of this enzyme can cause fetal adrenal hyperplasia. Central nervous system abnormalities and anencephaly, which is where the major portion of a brain, scalp, or skull is missing. And this also can cause some neural tube defects as well. And problems associated with the post-term infant include fetal macrosomia, placental insufficiencies, and meconium aspiration. We find that when babies have meconium, their first meconium in utero, oftentimes it's due to the stress. So if an infant is stressed, the anal sphincter will relax and will release the meconium. So being in an environment where you are post-term, you have a placenta that's not functioning as well, you have decreased amniotic fluid, you have decreased room because the fetus keeps growing, so they're becoming macrosomic with less room to move around. That puts a stressor on the fetus, and a lot of times, again, that anal sphincter will relax and they will release meconium. And once they're born, they're at higher risk for aspirating that meconium with that first breath. And keep in mind, IUGR and SGA are different, and people often get those two confused. An IUGR baby has not reached their growth potential due to a number of factors, but they may not fall below that 10th percentile for weight or length. They still may be above that, but not where they should be to their growth potential. Whereas an SGA baby will always fall below that 10th percentile, and otherwise they're normal, if you will, everywhere else. So assessment findings of the post-term infant are dry, peeling, or cracked skin, a lack of vernix, long fingernails, a thin, wasted appearance, meconium staining due to being in the meconium amniotic fluid for a while, and hypoglycemia. So this very dry, cracked skin is a result of the lack of or the lessened amniotic fluid around them, and also being in fluid a longer period of time than the average newborn. And again, they're at risk for aspirating that meconium. So fetuses that pass the meconium stools in utero as a response to stress because of the lack of oxygen or the placental insufficiency, this meconium aspiration syndrome can occur when, again, the infant or the newborn breathes in and then aspirates that meconium in their first breaths. This can lead to respiratory distress, inflammation of the lungs or pneumonitis, and an increased risk for lung infection. Signs and symptoms of meconium aspirate syndrome is cyanosis, tachypnea, or grunting in the newborn. You can see this aspiration on chest x-ray. Newborns may require suctioning at birth, supplemental oxygen, antibiotics, and sometimes assisted ventilation if they're really having difficulty breathing. It can be fatal if it's severe enough. It's the most common in the post-term infant due to the less amniotic fluid volume per higher concentration of meconium per volume. So they have less fluid, higher concentration of meconium per volume of fluid, and that is where they're at highest risk for aspirating that meconium and the amount that they have in there. So this is just a picture of a baby who not only passed meconium but had a little bit of meconium staining. You can see the whole body is a little yellow. And again, the wasted appearance, and this baby obviously is requiring some assisted ventilation due to the meconium aspiration. We're going to talk about preterm neonates. Those are at high risk as well. When we talk about preterm, we look at them in a couple different categories. So we look at very premature, which is less than 32 weeks gestation, premature, which is born between 32 and 34 weeks, and late preterm, which is born between 34 and 37 weeks. The birth weight can be extremely low birth weight, under 1,000 grams or 2.2 pounds, very low birth weight, which is under 1,500 grams, which is around 3.3 pounds, and low birth weight, which is under 2,500 grams, which is 5.5 pounds. And again, prematurity and low birth rates are not the same thing. You can be both premature with a low birth weight, but you can be one or the other without having to have the other. Infants that are born before 37 weeks, and I believe in your book in some places it might state before 38 weeks instead of 37. However, don't get caught up on this number. That's kind of one of those gray areas that you might see change from book to book. You have an increased incidence of complications and mortality, and it's roughly proportional to the degree of prematurity, meaning the more premature a baby is, the higher the risk of complications and mortality. So preterm birth is the cause of more deaths during the first year of life than any other single factor. It has a high percentage of birth defects. Remember, if a fetus is born before or during fetal growth and maturation is supposed to be occurring, you're stopping that natural process, and this is where birth defects can come in. The less the preterm weighs at birth, the greater the risk to life during delivery and immediately thereafter. The late preterm infant, again, those infants born between 34 and 37 weeks, we call that a late preterm infant. They have needs that are similar to those of the preterm infant regarding respiratory issues, sometimes feeding problems due to a poor suck-swallow reflex. They can have long-term cognitive and behavioral issues. Babies that are at increased risk have problems with thermoregulation, hyperbilirubemia, and sepsis. In the premature infant or an infant born before 34 weeks gestation, complications related to the dysfunction of the immature organ systems can occur. And remember, a premature infant will have complications in almost every single one of their organ systems: cardiac, central nervous system, eyes, GI tract, infection, kidneys, lungs, metabolic problems, and thermoregulation issues. So first we're going to look at cardiac. So there's a condition called patent ductus arteriosus, and the PDA is the communicating shunt that's between the pulmonary artery and the aorta. And this can become infected and can require antibiotics. This PDA is more likely to fail to close. It's increased risk with increased prematurity, and about 1/3 to 1/2 of infants with PDS or patent ductus syndrome have some degree of heart failure. So neonates that are born before 30 weeks gestation, the duct will usually, on its own, spontaneously, in about 98% of cases, close on their own before discharge from NICU. In the central nervous system, complications can include poor sucking and swallowing reflexes, apneic episodes, intraventricular hemorrhage, developmental and cognitive delays, feedings, usually through IV or gavage, and gavage is a nasogastric tube that's inserted to the stomach that can carry express breast milk or formula to the infant. Oxygen support or isolettes that are needed. We do something called cluster care with these babies, which means we cluster our care all at once, meaning that if we had to feed, we would do the diaper change at the same time, we would do the medications at that time, we would do the turning them at that time, so that everything's done at once, and then the infant is left alone for long periods of time. Those infants do not tolerate stimuli well as a premature infant and can cause stress to them, including things that we see with vital signs and feedings and thermoregulation. So it's best that we cluster our care when we're caring for these premature infants so that we don't exhaust them by continually bothering them, if you will, or continuing to do things to them. We kind of cluster everything in pockets. They will require ophthalmology as well as pediatric neurologist consults. And then a lot of early intervention programs. There's going to be a lot of referrals or setups for physical, occupational, and speech therapies that are going to be set up initially in the hospital so parents can continue with this when they bring the infant home finally. Another complication can be periventricular or intraventricular hemorrhage. So these are common forms of intracranial hemorrhage associated with preterm births, respiratory distress syndrome, and those on mechanical ventilation. So this is bleeding at the ventricles, and if it persists, blood will dissect into the adjacent ventricles. Assessment findings on these babies can be a sudden change in their condition, so oftentimes abrupt, bradycardia, a decrease in their hemoglobin and hematocrit, a full anterior fontanelle, and seizures. Management is measures to prevent the asphyxia, blood transfusion as needed, and we measure that head circumference to look for that extra intracranial hemorrhaging that may be occurring, and the head is getting bigger, the circumference. When we talk about in the eyes, the complications that can occur in these ocular complications are retinopathy of prematurity, or what we call ROP. And this is injury to the retinal blood vessels that are associated with the increased use of oxygen that are often used with premature infants. So premature eyes have immature vessels that constrict, and they obliterate as well as proliferate new ones, but this can cause scarring. And with that, retinal detachment can occur. And this will usually manifest between gestational ages of 32 and 34 weeks. They can also have complications with myopia and strabismus. Myopia is nearsightedness, and strabismus is the misalignment of the eyes due to the 3 cranial nerves becoming damaged. So this retinal vasculation is not complete until term. So this can lead to what abnormal vessel development and defects in the eyes, which is why oftentimes premature babies require glasses, because they have myopia, or they can have blindness. So again, strabismus is the disorder in which the eyes don't look in the exact same direction at the same time, and then myopia is that nearsightedness. When we talk about retinopathy of prematurity, we talk about the separation and fibrosis of the retina that can lead to blindness. So this is damage to those immature retinal blood vessels thought to be caused by high oxygen levels or low birth weight, or both. And remember, low birth weight is less than 1,500 grams. So maintaining sufficient levels of vitamin E and avoiding excessively high concentrations of oxygen can help prevent ROP from occurring. And then if this does occur, there is a treatment with cryosurgery that can reduce long-term complications and scarring. When we talk about complications that can occur in the gastrointestinal tract, we're talking about things like feeding intolerance, increased risk of aspiration, and a condition called necrotizing enterocolitis, or what we call NEC. And these are all complications that can occur because of the small stomach, the immature sucking and swallowing reflexes of the preterm infant, the inadequate gastric and intestinal mobility of the preterm infant. So necrotizing enterocolitis happens when tissues in the small or the large intestine are injured and begin to die off. This causes the intestines to become inflamed and develop either a hole or some sort of perforation, which is rare, but it can occur. And it's usually due to the immaturity of the bowel. This manifests in bloody stools in the infant, a feeding intolerance, or a look of a distended abdomen. It's the most common surgical emergency in the preterm infant. The complications include bowel perforation, intra-abdominal abscesses, stricture formation, short bowel syndrome, septicemia, and possibly death. And the increase goes up in necrotizing enterocolitis if you feed them too much or too soon as a preterm infant. Their small, immature bowel just can't handle that. So we often will look at giving the babies express breast milk if possible, because we find that there may be a preventative effect with the breast milk because of the immunoglobulins that are passed through that breast milk, that this can help perhaps stop or slow the formation of the necrotizing enterocolitis to occur. And this is just a picture of what happens to the inflammation of the bowel, of what that would look like. Surgery obviously is a treatment for this, bowel rest, and again, giving them that express breast milk because of those preventative and immunoglobulins that are passed through. They can also have a condition called esophageal atresia. This is a congenital malformation in which the esophagus stops before reaching the stomach. The signs and symptoms of this can be vomiting, abdominal distension, coughing, excessive oral secretions, and choking. And you can confirm this diagnosis if you cannot pass an NG tube through. It becomes a definitive diagnosis if we are not able to do that. Signs and symptoms of esophageal atresia are vomiting, abdominal distension, like I said, and so if you were to suspect this, you would try to pass that NG tube through to see if it is definitively an esophageal atresia, which, by the way, Remember, we said anytime you disrupt the normal fetal formation, this can occur. Things where connections don't reach their end point where they should be because they were stopped or abruptly ended before they were able to do so. Another condition is tracheoesophageal fistule, which is an unnatural connection between the esophagus and the stomach. And then they can have something called an impertinent anus, where they have an absent or an undeveloped anus. So it's very important that we look for the first meconium. We give the newborn about 24 hours to have their first meconium. If they haven't passed one by that point, oftentimes we will do rectal stimulation with a thermometer to see if we can get them to go. If that doesn't work, we might start to suspect, especially in the preterm infant, that they have an impertinent anus, and then that will require further testing. Another thing that goes into the GI and GU is when we're talking at the penis, we're talking about two conditions that can occur, a hypospadias or an epispadias. A hypospadias is when the urethral opening, which is normally at the tip of the penis, is now under the penis. And an epispadias is that it's now on top of the penis. So this is a normal urethromeatus here at the tip. A hypo would be where the opening is underneath, and a epispadias is when the urethral opening is on top. This can lead to urinary tract infections and infertility down the road. Circumcisions are often delayed or deferred until later because they will oftentimes use the foreskin that they would normally remove and discard with a circumcision to help correct this abnormality. Another complication in the preterm infant is infection, and that's a big one. So sepsis and meningitis are two of the common things that can occur. It is 4 times more likely to occur in the premature infant than in a term infant, and it can result from indwelling catheters that are placed in them, IVs, endotracheal tubes, skin breakdown, and the reduced serum immunoglobulin levels. If it's an early onset infection, it's usually caused by GBS from the mom or E. coli. And in the late onset, it's usually caused by staph or strep, which are typically hospital-acquired infections due to all the invasive procedures we're doing with them, like catheters and IVs and tubes. In the kidneys, the complications include metabolic acidosis, growth failure, renal function can be limited, and they can have decreased concentration and dilution ability. They have the inability to excrete fixed acids, which can accumulate with high protein formulas, and sodium and bicarb are lost in the urine. There's common disorders of the metabolism. So inborn errors of metabolism involve a genetic defect that may not be apparent until after birth. Now, this is not just specialized to the premature infant. This can happen in a term infant as well. So symptoms to report are lethargy, poor feeding, hypotonia or poor tone, a unique odor to the body or the urine, tachypnea, and vomiting. So we do newborn metabolic screening. So this must be done after 24 hours of life because we have to give that 24-hour time so that the newborn can produce digestive enzymes and rise, because it's the actual digestive enzymes that we're testing within this blood type. It's a blood test, and you can notice that there's 5 circles here. They prick the heel, they fill up these 5 circles with blood, and then that sample for all babies in Ohio at least are sent to a lab in Columbus, and they test these digestive enzymes for over 100 different metabolic disorders that can occur. So one of the more common metabolic disorders is called phenylketonuria, or what we commonly call PKU. So I will tell you that this is such a common thing, and it's one of the, I shouldn't say it's the most common thing, it's one of the more common of the metabolic disorders, and it's one of the first metabolic disorders we started to test. So you will hear in the hospital setting that a lot of doctors and nurses refer to this test as the PKU test because it was the first. But it really is a newborn metabolic screen, and it tests more than just PKU. So if this condition occurs, this PKU condition, this is a lack of enzyme. The baby is born with a lack of an enzyme that converts the phenylalanine to tyrosine, and it can lead to cognitive and physical problems. Things like delayed development, neuro issues, seizures, microcephaly, or eczema. And when a baby is found to be born with this condition, they will have dietary restrictions of phenylalanine for the rest of their lives. And this is found in high protein foods. So something to keep in mind. So not only do we have to wait the 24 hours to test because we wait for those digestive enzymes, it's not something that if they do have one of these metabolic disorders, that's going to affect them initially in life. So nothing that's in breast milk or in formula is going to cause a problem. It's going to be a problem when these babies become toddlers and start doing table food. So this test will be done at around, like I said, after 24 hours before they go home from the hospital. It gets sent to a lab. The lab results are not sent back to the hospital. They will be sent to the pediatrician that the baby's going to be going to. And this could take a few weeks before they get these results. And they'll still get them in time before the baby starts to eat table food. So once this baby has a diagnosis of any kind of metabolic disorder, they have this for life. So if they lack this enzyme, there's nothing they can do to start producing this enzyme. They just don't have it. So they can take supplements of certain things, but they will also have to do food restrictions for the rest of their lives to avoid certain foods that they do not have the enzyme to break down. Another common metabolic disorder is called maple syrup urine disease or maple syrup syndrome. This is genetically inherited and gets its name because it causes the urine and the sweat of the baby to smell sweet like maple syrup. It's a defect in the metabolism of branched chain amino acid. It causes marked serum elevations of leucine, isoleucine, and valine, and this can be fatal to the newborn or to the child when they start eating table food. They need a low protein diet and oftentimes dialysis. And if they were to eat foods that were high in these elevations and the things I mentioned earlier, this could lead to muscle rigidity, weakness, weight loss, and lethargy. Another condition is galactosemia. This is when the baby is born with they're lacking an enzyme that converts galactose to glucose, and they have the inability to metabolize lactose and sugar. So they obviously need a lactose-free diet because this could lead to damage to the liver, the brain, and the kidneys. Now we're going to move on to the lungs. Pulmonary complications can include respiratory distress syndrome and bronchopulmonal dysplasia, or what we refer to as BPD. And the latter is a result from acute lung injury from the oxygen treatment that they receive. So due to the lack of surfactant production, we know when surfactant starts to get produced is in those later stages of gestation. So obviously if they're born before surfactant has started to produce or before it completes its optimal level, they're going to have issues with alveoli collapse and atelectasis. So surfactant replacement therapy can be used, and this is often used through endotracheal tubes to help replace the surfactant that their body has not made yet or has not made enough of. A chronic lung disease could develop, which is that BPD, with the prolonged need for a ventilator. So these infants, because they're put on a ventilator due to the alveolar collapse, they get dependent on the ventilator, and they have a hard time being weaned from it, and this is part of this BPD. So this can result in tachypnea, tachycardia, and retractions in the newborn. So respiratory distress syndrome is a result of immature lungs that leads to a decrease in gas exchange. Surfactant, again, is that fatty protein that's high in lecithin, and its presence is necessary for the lungs to absorb oxygen and to do oxygen and perfusion. It begins to form again around 24 weeks gestation. It's usually optimal by about 35 weeks. And if the fetus is delivered before that, if they're delivered after that, they should be able to breathe adequately. However, if they are born premature, the level is insufficient. So we talked earlier that one of the things we can do, especially with a delivery that we think is imminent or unstoppable, we will give betamethasone, which is that steroid to mom, in an IM injection to increase the production of surfactant to the baby. And this is just a picture of an x-ray of a baby who's starting to have respiratory distress syndrome, and this is just another drawing of normal alveoli versus the collapsed alveoli. Respiratory distress syndrome findings that you would find on assessment would be that the respirations would be tachypnic, so they would increase 60 breaths a minute or higher. Tachypnea may be accompanied by grunting, nasal flaring, which we know are signs of oxygen hungry or the need to work harder to get oxygen, cyanosis, as well as intercostal and sternal retractions. The skin can become gray or dusky, breath sounds are decreased, and you may even hear rales when RDS gets worse. The infant can become lethargic or hypotonic. Acidosis with hypoxemia may occur, and they may require mechanical ventilation. The treatment to RDS in preterm infants, surfactant again can be administered via the ET tube at birth or when symptoms occur. A CPAP or mechanical ventilation would be necessary, possibly to assist them in breathing. Antibiotics as indicated. We would monitor vital signs, including their pulse oximetry. Again, the minimal handling of the infant to help conserve their energy, that's part of that cluster care. And oxygen level assessment is critical. We want to be careful with how much oxygen we're supplementing because we want to watch for oxygen toxicity that can cause injury to the infant's eyes and lungs. Another condition is called persistent pulmonary hypertension. This is seen in neonates who experience hypoxia, asphyxia, respiratory distress syndrome, and meconium aspirate syndrome. And this results when the normal vasodilation and relaxation of the pulmonary vascular bed do not occur. And its elevated pulmonary vascular resistance is when right ventricular hypertension occurs and right to left shunting of the blood through that threminal valley. And this can cause congestive heart failure, kidney damage, and liver damage. Signs and symptoms that you may have a baby with pulmonary hypertension would be low APGAR scores at birth, hypoxia or asphyxia shortly after birth, tachypnea, retractions or grunting, a low PaO2, cyanosis, a heart murmur that's noted, or it can be diagnosed on an echocardiogram. Treatment for PPH is rapid resuscitation, hyperoxygenation, umbilical catheter for IV therapy and monitoring for hemodynamic status. Umbilical catheter is when we put a catheter through the umbilical vessels versus a vein in like their arm. So this is a good way to get high blood volume medications or blood products. And it could also where we can monitor hemodynamic status. And it can be placed right at the time of birth while the vessels are still open and they're still visualized so that you can put that catheter through. So medications that they may require are vasopressors, vasodilators, muscle relaxants, sedatives, and antibiotics. Bronchopulmonary dysplasia, which we just talked about, is that chronic lung disease. It's more common in preterm infants. We know it's when lungs and bronchi are damaged or scarred or inflamed, and it's the dysplasia of the alveoli occurs. This results from damage to the lungs because of the mechanical ventilation or long-term use of oxygen. So oxygen supplementation and mechanical ventilation can damage the alveoli, which requires the infant to need more oxygen and more mechanical ventilation. So it's kind of very cyclical circle that's hard to get off of. So it's difficult to get them off mechanical ventilation once they require mechanical ventilation. And again, you would see chest retractions, audible wheezing, rales, bronchi, hypoxia with respiratory acidosis, bronchospasms, and again, a difficulty in weaning them from the ventilator. So bronchodysplasia, we know preventative measures are going to minimize the barotrauma and the volutrauma. We're going to minimize oxygen toxicity. We're going to pay careful attention to the intake of fluid and sodium. And again, the treatment is adequate caloric intake. After 36 weeks of gestation, we want to maintain their O2 stat at least 95% or greater. We want to restrict the intake of fluid and sodium. We want to use diuretics, bronchodilators, steroids are almost never indicated in this case, and we use infection prevention. And going back more about the metabolic problems, we're going to talk about complications including hypoglycemia and hyperbilirubemia. So infants can have difficulty maintaining blood glucose levels, as well as difficulty breaking down that bilirubin due to the immature liver or decreased intestinal motility. So there's more unconjugated bilirubin that can build up if they're not excreting it through the meconium, and this can lead to kernicterus, which is brain damage. Another problem they can have is temperature regulation. So one of the complications can be hypothermia. They have a large body surface area to volume ratio in the preterm infant. and exposure to temperature can be greater than the neutral thermal environment, and it leads to rapidly losing heat and having difficulty then maintaining their body temperature. So this is one of those things that we really, really want to encourage kangaroo care or skin-to-skin contact, where the infant only wears the diaper and is placed on the parent's naked chest. It not only warms them, but calms them and can promote bonding. As long as the preterm infant can tolerate it, because remember, some preterm infants cannot tolerate a lot of stimuli. Positioning is key in the preterm infant. You want to place them on their side or in a prone position with the head of the mattress slightly elevated, like you see here with this preterm newborn down here. It decreases their respiratory effort and improves their oxygenation. And it promotes a more organized sleep pattern and lessens the physical activity that's required, which is burning up energy for needed growth and development. It should be compatible with the drainage of secretions and prevention of aspiration. And you never want to leave the preterm infant in one position for too long of a time. Because their skin is so fragile and thin, they have a high risk of skin breakdown. And this is a picture of a preterm infant that had skin breakdown from being left on the chest too long. Physical assessment findings of the preterm will be that transparent skin, those superficial veins that are visible on their abdomen and scalp. They'll have a lack of subcutaneous fat. They'll have lanugo covering all over their forehead, their shoulders, their arms. They have an abundant amount of that vernix caseosa. The soles of the feet will have few to no creases. Their eyelids may be fused. Pinea over the ear is going to be thin, soft, flat, and oftentimes folded without that spring or that recoil. They will have a weak or absent cry. Their reflexes are absent or diminished, and you will often notice a heart murmur due to the fact that the ducts are still open. Resuscitation. Preterm infant will likely require some form of resuscitation at birth. It's important that we're doing it in this order. We always stabilize the infant, we dry them, we place them under a radiant warmer, we clear their airway with a bulb syringe, and then we stimulate breathing. If they require ventilation at that point, we do that. And then chest compressions as well if that is needed. And then we administer medications. Epinephrine is one that they can use, and it can be administered through an umbilical catheter if one is placed. And again, we need to be cautious that we're not giving them too much oxygen. We talk about a newborn pain scale. Now we can do this on both the preterm infant as well as the normal term infant. This is a neonatal infant pain scale where we look at different features of the newborn to assess their pain. So the scale is composed of 6 indicators: the facial expression, their cry, their breathing, their arms, their legs, and their state of arousal. So this is the typical NIPS score that we use. We give them either a 0 or 1 or 2 based on their facial expression, cry, breathing, arms, legs, and alertness. And that's how we score them for pain. We do that when we're doing vital signs. We do that after a painful procedure like a blood draw, a circumcision, and then we can also do a pain rescore after we've either finished the treatment we were doing. We gave them a medication like Tylenol, we swaddled them, fed them, pacifier, anything that we did to reduce the pain or calm them. Then we can use the scale again to do a rescore. We talked a little bit about neonatal abstinence syndrome earlier, where this is a problem that occurs in the newborn who is exposed to addictive drugs, often opiates, in intrauterine environment. Infants they'll develop a dependence on this drug while in the womb, and then they continue to be dependent even after birth. So just because the baby is no longer receiving the drugs now through the placenta, withdrawal is going to occur or may occur. Causes of NAS that can occur when a woman who's pregnant takes drug are usually from heroin, codeine, oxycodone or oxycontin, methadone, or buprenorphine. These substances all cross the placenta, and withdrawal symptoms will occur or may occur as the drug starts to slowly get cleared from the body's system. This is usually at or after 48 to 72 hours after birth. So you don't initially see withdrawal symptoms in the first 24 to 48 hours. And withdrawal may occur with exposure to alcohol as well, benzodiazepines, barbiturates, and certain antidepressants that are categorized as SSRIs. Symptoms of the opioid-induced NAS baby will be the high-pitched cry, jitteriness, tremors, convulsions, fever, sweating, vomiting, diarrhea, mottling of the skin, difficulty sleeping, loss of appetite, and dehydration. And this is an example of a scale we use when we're scoring an NAS baby. And notice they talk here about a high-pitched cry, about their sleeping patterns, their hyperactive Moro reflex or startle reflex. If they're noticing any tremors, they look at their muscle tone, they look at their general skin, they look to see if they have a fever, if they're doing frequent yawning or sneezing, which is a hyperactive reflex that can occur when they're exposed to opioids, excessive sweating, nasal stuffiness that you'll hear in the nose when they're trying to breathe, tachypnea, poor feeding, vomiting or regurgitation after feeds, loose stools, 90% of they're losing, a great amount of their birth weight, excessive irritability, and then they total the score. Usually they'll start to score them when the baby starts to exhibit some of these symptoms. And again, that's about 48 hours to 72 hours. And once that score reaches an 8, that's when intervention is necessary, meaning medical intervention as far as medicines go. So usually at this point, babies are transferred to a NICU unit or a hospital that has a NICU unit, and they oftentimes will give these babies morphine and other medications to help alleviate a lot of these withdrawal symptoms. Another condition is neonatal asphyxia. This is newborns who fail to establish adequate or sustain adequate respiration after birth. Clinical manifestations can come from compensatory mechanisms like an increased heart rate or vasoconstriction. Hypotension, bradycardia, cyanosis, hypotonic, and unresponsiveness can occur, and these babies may require resuscitation. The infant of the diabetic mother is at high risk. The placenta will produce hormones like estrogen and cortisol and human placental lactogen to maintain the pregnancy. These hormones that are produced to maintain the pregnancy also can block insulin. So usually it begins around the 20th to 24th week into the pregnancy. As the placenta grows, more of these hormones are produced and more insulin resistant it becomes. So normally the pancreas is able to compensate for this by just making additional insulin. But when that production is not enough, or that mom cannot compensate and make enough of that insulin, then gestational diabetes occurs. So pregnancy can also change your insulin needs of a woman who had pre-existing diabetes. So insulin-dependent mothers may require more insulin as the pregnancy progresses. Or maybe a mother who had diabetes but was doing it with diet control may now need to go on insulin. Or maybe if she was on oral medication, she may need to now switch to insulin due to the extra pressure it puts on the body with pregnancy. So we know large amounts of glucose are transferred to the fetus from mom. This causes the fetus to become hyperglycemic. Then the fetal pancreas will produce large amounts of fetal insulin to combat the amount of hyperglucose they're getting. And this leads to hyperinsulinism, which along with the excess production of protein and fatty acids is what causes issues in the newborn with the hypoglycemia when they can't maintain those adequate glucose levels after birth. So the newborn assessment is where oftentimes they are macrosomic as a result of the amount of glucose they're receiving in utero. So they're usually over 90% percentile or that LGA range or over 4,000 grams. It occurs in about 15 to 45% of diabetic pregnancies. The infant can often appear puffy or what we call fat or ruddy or hypotonic. They may also have the hypoglycemia, respiratory distress syndrome, hypocalcemia, and hyperbilirubemia. And many need to be born via cesarean section because they just simply cannot fit through the birth canal. And if they do try a vaginal delivery, we also have complications with shoulder dystocia and potential brachial plexus injury. The treatment is to provide early and frequent feedings. We want to monitor glucose levels. Blood sugar should be blood sugars less than 40 milligrams per deciliter can result in permanent brain damage. So we want to make sure that we're monitoring the blood sugar levels. They need to be over 40 milligrams because that brain needs glucose. So we'll make sure that we're monitoring vital signs. We look for signs of irritability or tremors or respiratory distress. And then again, we're going to touch on hyperbilirubemia, which I know we talked about a lot in the normal newborn. That's that high level of bilirubin in the blood, usually over that 5 milligrams, specifically in that first 24 hours. It's characterized into the physiological and the pathological jaundices that we talked about, the two types. And a complication of hyperbilirubemia is kernicterus, which is abnormal accumulation of unconjugated bilirubin in the brain cells, and then that can lead to permanent brain damage. This can cause neurological disorders like deafness, delayed motor skills, hypotonia, and intellectual difficulties. And the treatment for hyperbilirubemia can be bililytes, which can help the infant break down the bilirubin, frequent feedings to help them excrete the meconium through the stool, and excrete the bilirubin that's in the meconium or their stool. And then natural sunlight can do something just as effectively as these bililytes if they're able to be exposed to high levels of natural sunlight on a daily basis. And again, physiological jaundice is the excessive bilirubin due to the newborn's immature liver. They're having difficulty removing the bilirubin quick enough. Again, typically peaking on that like third day, somewhere between the second and fifth day of life. It's due to the breakdown of the red blood cells that's releasing the bilirubin into the blood, plus the immaturity of the liver, which cannot effectively metabolize the bilirubin, and it prepares it for excretion. And then the physiological jaundice of the newborn is also referred to as neonatal hypobilirubemia or neonatal jaundice. That's a very common phrase, the neonatal jaundice. And again, that pathological jaundice is that excessive number of red blood cells are now being broken down or hemolysis occurring. This is due to an ABO and RH incompatibility. It could be due to birth trauma or bruising or infection. And that jaundice will appear much sooner, within the first 24 hours, and it rapidly rises to a total serum bilirubin concentration that's more than 5 milligrams per deciliter per day, and a total serum bilirubin, that level of 16 milligrams per deciliter or greater. Breastfeeding can also cause jaundice. There's a breastfeeding jaundice as well as a breast milk jaundice. So breastfeeding jaundice is seen in breastfed babies during the first week of life, and is more likely to occur when babies do not nurse well. So we talked about all the different problems that a baby can have trying to nurse. So this is where the mother's milk is slow to come in, or the baby's a poor feeder, and it can cause jaundice due to the whole not eating and excreting enough. Breast milk jaundice can appear in breastfed babies after about the 7th day of life, and it's likely to peak during weeks 2 and 3. This can last as low levels of this for a month or more. And the problem is associated with how substances in the breast milk affect the breakdown of the bilirubin by the liver. It's not as common. Congenital heart disease is when the cardiovascular system we know will develop between the 3rd and 8th week of gestation. So if anything is interrupted, after that time while it's still trying to develop, we look for suspected cardiac pathology. So a failure to thrive, a baby who fatigues easily during feedings or turns cyanotic or pallor during feedings specifically, visual pulsations in the neck veins, tachypnea or dyspnea, irregular heart rate, the clubbing of fingers, excessive perspiration on the head, or a loud, harsh murmur. Common cardiac anomalies are atrial septal defect, patent ductus arteriosus, ventricular septal defect, which is a duct that fails to close, or tetralogy of Fallot. And 4 things occur in the tetralogy of Fallot: a hole in the heart, an obstruction from the heart to the lungs, the aorta lies over the heart, and the muscle of the heart thickens. Other cardiac anomalies that can be common are transposition of the great vessels. This is when there's an abnormal arrangement of vessels, the inferior and superior vena cavas, the pulmonary artery and the pulmonary veins, and the aorta. There could be a coarctation of the aorta, which is a narrowing of the aorta. There could be trunctus arteriosus, which is an improper divide from the pulmonary trunk to the aorta. There could be hypoplastic left heart syndrome, which the left side of the heart does not develop normally, and this can affect the way the blood flows. Some treatments for these cardiac conditions can include medications like prostaglandin E1s and surgery. Neural tube defects can be anencephaly, which is where you're born without parts of the brain or skull. Spina bifida, where there's an incomplete closure of the spine during development. Microcephaly, where the baby is born with a small head and small brain. and hydrocephalus, where cerebrospinal fluid on the brain creates pressure on the tissues of the brain. Other common congenital anomalies can be a cleft lip or palate. A special syringe or bottle is needed to assist these children in feeding until surgery can correct the malformation. We want to make sure we're giving these babies high-calorie formula. We burp them frequently due to the excessive amount of air they may take in while feeding. They need to sit upright with feeding and right after, and we need to limit the duration of feedings. They can't tolerate a large amount of feedings for a long period of time. So in this case, you see this is a cleft palate, where the cleft is right in the palate, and this is where it's both in the palate and the lip, so the roof of the mouth through the lip, and both require surgery. Another condition is called talatonus equinovarus. This is a deformity of the foot or the ankle, or what we would commonly refer to as clubfoot. It's diagnosed by the typical appearance of a baby's foot after they're born, so we can just see it. That's our diagnosis right there. We use something called the Ponseti method to help treat this. It's widely used for these, and it gives good results without having to resort to surgery, although some babies do require surgery. This method involves just gently manipulating the child's foot into the position it needs to go to, by then maneuvering it to that position and then putting a plaster cast over it to hold it into place, and then continually repeating this manipulation and casting of the foot, one after the next, changing its position, which is a usual slow but good progress on how the foot is then positioned back to its original normal spot that it should be in. Another condition that can occur is called hip dysplasia. The exact causes are unknown, although they feel that it could be due to the fact that their bones are ossified more than calcified, so they're soft bones and they can easily be displaced. It can be developmental. It can develop around the time of birth. The baby's womb and position can cause more pressure on hip joints, and breech positions are linked more with hip instability than a vertex position. And again, that softer hip bone cartilage is easily dislocated. So this is again showing a dislocated hip. These are two tests you can do to look for a dislocated hip, the Barlow test and the Ortolani test. The Barlow is just simply pulling the leg straight to see if they have evenness to the legs, and the Ortolani test is gently abducting the legs back to see if you hear an audible click. This is called a Pavlik harness, which they use to keep those hips in the socket until the bones start to calcify and those hips stay in place without needing this harness. Another complication can be a fetal demise. So if this occurs, we want to make sure that we are giving supportive care, offering a baptism if that's what the parents prefer, providing them with memorabilia, which could be locks of hair, footprints or plaster molds of the feet or hands, a hospital bracelet. We want to encourage parents to participate in the newborn's care, hold and touch as much as tolerated, and then we do take pictures for parents to take with them. And again, I think I mentioned this before, some parents can't tolerate it at the time because of the state of grief that they're in. So we hang on to these memorabilia and these pictures for long periods of time, so that if a parent comes back at any point in time and wants to see those plaster molds, those footprints, those pictures, we have them on file. Another complication once a baby is born is SIDS, which is sudden infant death syndrome. This is an unexplained death, usually during the sleep, of a seemingly healthy baby that's less than a year old. It's also known as crib death because the infants often die in their cribs. The risk peaks in infants at about 2 to 4 months of age, and then it declines. So remember we talked about establishing good breastfeeding, and we said that for the first month, the American Academy of Pediatrics does not recommend using a pacifier until you can establish good breastfeeding. They then recommend using a pacifier once breastfeeding is established and the baby is now 2 months. Because of that increased risk of SIDS, using a pacifier decreases the risk of SIDS. So sleep environmental factors can take place because of the SIDS. Items in a baby's crib, like a bumper pad, extra fluffy blankets, teddy bears, those can all contribute to SIDS. Also, their sleeping position can combine with the baby's physical problems to increase their risk. So we want to make sure that we see that sleeping on their stomach or their side positions is not recommended. Babies might have more difficulty breathing than those that are placed on their back. So there's a big campaign that'll say back to sleep. That reminds parents to put the babies on their back to sleep. SIDS risk factors can be, they're a higher risk factor if they're a preterm birth, if they're a low birth weight, babies that are born to moms under the age of 20, statistically if they have found this. Certain ethnic groups can play a role in this, and male infants seem to suffer from SIDS more than female infants. We want to educate our patients on how to provide safe sleep for their baby and reduce the risk of SIDS. Always put a baby on their back to sleep. Choose a safe crib, bassinet, or play yard that has a firm sleeping surface and is free of pillows, stuffed animals, or any kind of soft bedding. You can sleep in the same room as the infant, but it is not recommended that you sleep in the same bed. One, because of the soft mattress and the pillows and the blankets, but also because parents have been known to roll over on their infants in a very, very deep sleep. Don't let your baby fall asleep on a couch or an armchair or any other plush surface. You want to avoid overheating of your baby, so make sure that you're not dressing them overly in blankets and sleepers. Just a normal, comfortable sleeper is fine. Keep your baby away from cigarette smoke and any kind of second and third hand cigarette smoke. Breastfeed if you can, because of, again, those immunoglobulins that are passed through that. And offer your baby a pacifier when you put them down to sleep, again, around that second month. And this is what safe sleep looks like. A firm mattress, an empty crib of blankets, stuffed animals, bumper pads, a baby who's in a snuggly that's tight to their body where it doesn't loose and come up by their face. So this is a perfect education on our parents on what safe sleep looks like. So that concludes our newborn high risk lecture.